try to put all these things. Yeah, okay. So we will play, and you have a QR code here, and in the next slide, in order to connect you, I will suppress everything in order to have a proper screen. So you can go to menti.com with the code or flash the QR code in order to be with me and to see what do you think about this clinical case, that are true clinical case that occurred in my unit. So let's go. For a 55-year-old woman, she was quite obese. You see, 120 kilograms with a BMI of 43. It was an ARDS due to influenza infection with an ECMO, veno-venous ECMO that was started on February 10th. And you see, 5 days after, she was suspected for a VAP, a first VAP, and she received 2 days of cefepime. And due to the negativity of the BAL, we stopped antibiotic for 7 days, and there was another episode of suspicion of VAP, and this bronchoalveolar lavage grew with the methicillin susceptible Staph aureus and streptoanginosus, and we start for 7-day coamoxiclav. She developed a multiple organ dysfunction under ECMO with a tubular necrosis, and the hemodialysis was started on March the 1st. On March the 2nd, there was a local cannula infection due to Candida and Proteus mirabilis, treated by 5 days of caspofungin and 7 days of cefotaxime. The patients improve progressively, and the ECMO was wound on March 17th. And on March 19th, unfortunately, there was a second episode of VAP with a BAL that grew to Citrobacter causerii, 10 to the 6th, Proteus causerii, 10 to the 6th, and Haemophilus in E. coli, 10 to the 2nd. And it was treated for 7 days with meropenem. So we have all this thing in mind, and on March 26th, we perform a rectal and oropharyngeal screening with carriage, and unfortunately, the patients was carrying an Acinetobacter baumannii, and you see the antibiotic susceptibility test on the right part of the screen, and it was resistant to almost all the traditional antimicrobials. Here you have only resistance pattern, and we perform monoplex PCR for carbaphenemases, and it was positive with OXA23 and New Delhi metallo-beta-lactamase. So unfortunately, the same day, she was a new shock happened with the degradation of blood gases. The PF ratio, the PaO2 FiO2 ratio, was only 120. She received norepinephrine, high dose, and she was anuric. And the gram stain of the BAL fluid was with rare leukocytes, and the gram stain grew with show numerous gram-negative cocobacilli. So, my first question, what is for you the empirical therapy if we consider only Acinetobacter baumannii? So, I propose a few things. So, we will go to the next slide to vote. So I propose 9 grams of sulbactam, and of course you can choose more than one option. 2 grams of sulbactam. I propose colistin, 12 million unit loading dose and then 4.5 million units every 48 hours due to anuria and hemodialysis. I propose 4.5 million units every 48 hours, and that's it. I propose TIJ, 200 loading dose and 100 BID, or TIJ, 100 loading dose and 50 milligram BID, and nebulized colistin. So please try to vote to this question. Not so easy, but important to have your feeling on it. Of course, it is not easy at all. It was a lot of discussion with my staff, and a lot of things is not known at this time. I only know the carriage and the direct examination of the bronchoalveolar lavage fluid. So 27, I will see what are your feelings. So your feeling is to start colistin plus or not sulbactam, plus or not TIJ, plus or not nebulized colistin. So interesting. Clearly, there is some good things here. First of all, colistin is given with a very high loading dose, and you start with a high loading dose, and I think it is a good option because even in case of altered clearance, and here the renal function is really altered, you need to fill the sink, let's say, and you need to have a very important loading dose in order to be effective. Probably during the first day, I will have chosen 9 million units, that is to say 4.5 every 12 hours, probably. And sulbactam, if you have it, in France it is very difficult to have it, and we have only ampicillin sulbactam. Of course, 9 grams is good, and you should know, and you should have in mind that a very low dose is not effective. So you need to give at least 8, 9, and even 12 grams per day in some studies. So very difficult to reach this point, and the resistant, the efficacy of sulbactam is not clearly related to the susceptibility. So we don't know at this time, at this point. About nebulized colistin, it is the problem is the PF ratio, only 120. It is not so much, so the risk of complication is very high, and we don't know if we really give an extra chance to the patients doing it. So indeed, the risk for Acinetobacter baumannii pneumonia in this case is very high, since the patients were colonized with Acinetobacter in the throat, and you see that the risk for an infection after being colonized is more than 14% in all the meta-analysis of the data that exists worldwide, mainly in high-income country, unfortunately. So if you have it is available to have a new molecule, would you choose something? And I propose some option. Do you choose to add this kind of molecule, so you can again scan the QR code if you are disconnected? Let's go. So do you choose sulbactam durlobactam? Do you choose ceftazidime avibactam astreonam? Kefepime zidebactam? Cefiderocol? None of the above when you see these things. So please vote. It is interesting to look to your answers. So Acinetobacter baumannii, it is not susceptible. It carries OXA23 and also NDM, and you have this infection that we need to treat. And if you have these new molecules, which one do you choose? So I see that the majority will give sulbactam durlobactam. So you know, and David Livermore do not speak about it, but it is very interesting to have in mind this paper published a year ago about the efficacy of sulbactam durlobactam and VAP due to Acinetobacter baumannii. Unfortunately, it is only effective on OXA23 and not too much effective and not at all even effective on metallo-beta-lactamase carriers, Acinetobacter carriers. So unfortunately, sulbactam durlobactam will not be in this case a good option, despite its very interesting efficacy in OXA23. So in this case, probably not. You should know that ceftazidime-avibactam aztreonam or aztreonam-avibactam is not effective on Acinetobacter. So in this case, probably ceftazidime-avibactam aztreonam will not be a good idea, unless there is another gram-negative Enterobacterales that carry New Delhi metallo-beta-lactamase, but it was not the case in this case. Cefepime-zidebactam, I know that in some of the countries represented here, you have it, and cefepime-zidebactam is very interesting for Pseudomonas aeruginosa, but not really for Acinetobacter baumannii. So the chance for the molecule to be effective in this case is quite low. And cefiderocol, well, David Livermore spoke about it. And indeed, there was some clinical failure with cefiderocol in Acinetobacter baumannii infection, but it may work. But in this case, we don't know, and we need to have the susceptibility profile and the MIC before starting cefiderocol. So none of the above is at this time probably the good option for this question, or cefiderocol if we have chance, but it is not sure at all. So we have the antibiotic susceptibility profile, and you see here for the Acinetobacter, there was two germs in the bronchoalveolar lavage. In this case, there was a Citrobacter that was very susceptible, but also an Acinetobacter that was NDM carrier, OXA23 carriers, and OXA40 unknown carriers, of course. And you see here that the resistant profile was very, very important. The MIC for cefiderocol was resistant, 8 for MIC. And you see that for Tige, the MIC was not so good. There is no breakpoint. So we don't know at this time, but the MIC for Tige was not good. And David spoke about eravaciclines. The MIC was not so bad. And for colistine, the MIC was acceptable with susceptibility profile and MIC of 1 in this case. So it is important to have in mind that if you use MPCR for Acinetobacter baumannii, the target OXA23 and OXA24 are not in the MPCR that is usually commercialized. So it is really an issue. So if you have no carbapenemase identified by MPCR, such as the one of Filmare, BioFire, you are not sure that Acinetobacter is not a carrier for this OXA23. Of course, the NDM is recognized by the PCR, so it is very important to have in mind. So the clinical and biologist discussion is very, very important in this case in order to understand the interpretation of this MPCR in front of this kind of patients. So I think it is a very important message to have in mind. So for me, the treatment of Acinetobacter baumannii is, of course, to test and to discuss with the microbiologist and to perform MIC. And we need to choose this kind of molecules, ampicillbactam, Mino, Tige, eravacicline, and perhaps sulbactam durlobactam if you have it, with for OXA423, but not really for NDM. And probably we need to prefer combo or a 3 antibiotic therapy, mixing ampicillin sulbactam with high dose and colistine, and perhaps mixing with cyclines In this case, eravacycline was the choice, but it is not sure. And for cefiderocol, we know that there is some warning, and we need complementary data. There is some cohort studies that are in favor of the use of it. The other point that is very important is that we need to optimize PK for these very difficult to treat antibiotic therapy infections with difficult to treat resistant gram-negative bacteria. There is a high volume of distribution, so we need to have a very high dose at the very beginning and to decrease the dose when the patient is stabilized, but not at the very beginning, even if the renal function is very poor. The source control is very important, and the reevaluation after 24 to 48 days is a key in this case. So the follow-up was quite good. The sulbactam MIC was not good at all. We start with sulbactam eravacycline colistin and then eravacycline colistin IV, and the patient is stabilized and the noradrenaline was stopped. And you should know that for eravacycline in obese patients, the level of clinical cure is quite good. There is at least one study that show that the clinical cure level was similar for obese patients and thin patients. So you need to have it in mind, and with 1 milligram per kilogram and per 12 hours, it is feasible to reach a sufficient level of this drug. After 7 days of treatment, the new BAL was done because of fever and persistent ARDS. And in this BAL, we see on the MPCR an Acinetobacter baumannii complex 10 to the 6 copies, a Proteus species 10 to the 4 copies, and Pseudomonas aeruginosa 10 to 7, more than 10 to the 7 copies. And there was a presence of 2 carbaphenemases, NDM and VIM. And the method was the one of the BioFar Finland, so it is real life. So what is your suspected diagnosis here? I recall you MPCR 10 to the 6A baumannii, 10 to the 7 P. aeruginosa, VIM positive, and DM positive. So first, it is an Acinetobacter failure, the treatment. Acinetobacter, I don't know. I am waiting the BAL culture. Pseudomonas aeruginosa false positive, Pseudomonas aeruginosa superinfection, VIM false positive results, VIM true positive due to Acinetobacter baumannii. Here is the voting, so please vote. So CRAB, VAP, CRAB not interpretable, Pseudomonas aeruginosa false positive, Pseudomonas aeruginosa superinfection, VIM false positive, VIM true positive. So please vote. It is very interesting and very important, in my opinion, because the use of this very rapid test will be probably a very important solution for us. And David Livermore mentioned that it is very difficult to know at the very beginning what will be the drugs that are effective in front of this DTR gram-negative bacteria. And I think we need to learn how to use this kind of MPCR, even if the sensitivity and specificity is not perfect at all, as for every diagnostic test. So probably important to try to answer to this question. So we will look at your answers. So you consider that it is possibly a failure to treat Acinetobacter baumannii. You also may consider that it is not interpretable because the number of copy is not the mirror, it is not similar to the culture that go to Acinetobacter baumannii. Some of you consider that it is a false positive result for Pseudomonas aeruginosa. 2/3 consider that it is superinfection. 1/4 consider that it is a false positive for VIM, and only 21% that it is a true positive for VIM. So it missed some cases for VIM false or true positive, probably. Very interesting. So let's have a look to the results now and the interpretation. So the behavioral culture was totally negative for Acinetobacter baumannii. So you should know that after a few days of treatment, if the treatment succeed, you could have a residual DNA of Acinetobacter baumannii, but it is not a live Acinetobacter baumannii, but only DNA and residual DNA. So it is important to have it in mind. And in this case, there was a super infection with Pseudomonas aeruginosa that was positive with VIM, Verona metallo-beta-lactamases, and there was also for Proteus auxeri and ESBL. But that's it. So a problem to treat this kind of patients under tetracycline and colistin. And you see that probably colistin selects this proteus, and probably ravacycline was responsible for the emergence of Pseudomonas aeruginosa. So the solution for treating these patients could be to pursue colistin and probably to use cefiderocol in this case. You see that the MIC was quite good. One. So you should have in mind the false positivity of some MPCR after a few days of treatment, and that probably it is important to take into account this point when you are choosing the antibiotic for a superinfection. So here is the table for looking to all the molecules. You should have in mind that for Astreonam avibactam, Acinetobacter is not possible to use, and it is the case also for Ceftazidime avibactam Astreonam. You see that for Cefepimzidibactam, available in some country in temporary utilization, there is some Acinetobacter that are susceptible, but not all at all, not at all, not all the strains, and you should have it also in mind. And for cefiderocol, David Livermore told you about it. Another one, in order to finish my talk, it is patients with heart transplant recipient with a lot of complication, a septic shock, graft dysfunction, 15 days of ECMO, a candida colonization, treated for 10 days, and after 17 days of battle, of fight, he recovered, but there was an ischemic colitis that you see here. It was treated medically by cefotaxime-metronidazole and parenteral nutrition, and the patients recovered. You should know that in the CT scan that we performed, there was a thrombosis, a bilateral venous thrombosis at day 19. At day 26, he was successfully extubated. He was very conscious, no catecholamine, and he was still under hemodialysis, but the diuresis was good, 3 liters, so we were supposed to wean the patients from hemodialysis. He was transferred to intermediate care. The temperature was 38 degrees Celsius. The leukocytes was slightly increased, and the CVC and hemodialysis catheter were removed at day 26 without local sign, no pain, and one blood culture was taken because of 38 temperature. And unfortunately, 1 day after, we know that the CVC grew with 10 to the 4th Pseudomonas aeruginosa, 10 to the 3rd Enterococcus faecium, and the hemodialysis catheter grew to 10 to the 5th Pseudomonas aeruginosa. We performed monoplex PCR, and for both strains, there was NDM positive carbapenemase for Pseudomonas aeruginosa. My question, one blood culture was taken, and after 24 hours, it was negative. The patients were afebrile after catheter removal and well. So my question will be, do you treat these patients? And the treatment will be colistin, fosfomycin, vancomycin, for example. Or do you perform only a watchful waiting attitude? So in this case, what do you do? So let's have a look to your answer. I think it is very interesting and very important. Oh, interesting. Almost 1/3, 2/3. Treatment, not treatment. So it is it is an issue. It is very difficult. This case happened 1 month ago, so I have not the final answer. But you should know that if you look to patients with a catheter that is positive with Pseudomonas aeruginosa, if you are not treating the patients, you increase the risk of subsequent bloodstream infection. It was a study published in 2012 by a Thailand team, and you see that the risk was clearly higher with this kind of non-fermentative gram-negative bacteria in case of positive culture with catheter without positive blood culture. We perform another study with the outcome REA group looking to this problem, and we match patients treated and not treated when we are not able, even for Pseudomonas aeruginosa, to see a difference in mortality or superinfection due to a treatment or no treatment. So to treat the patients, we can say, yes, he is very immunocompromised. The temperature was 38 degrees Celsius. The microorganism is a non-fermentative bacteria that is capable to create problems. Only one blood culture was taken and no more, and there was an history of femoral thrombosis, so probably a risk for this catheter to be infected. On the contrary, we can say, well, there is no recent prosthesis or device, no organ failure, no sign of sepsis. It is not a Staph aureus, and we know that for Staph aureus, there is really an issue on not treating the patients. No exit site of infection, one negative blood culture, and finally, vancomycin and colistin are nephrotoxic for these patients that is weaned to antibiotic for hemodialysis very recently. So we choose not to treat and to stop antibiotic in this case, and it was a month ago. And after 4 weeks, there is no problem. The patients had no new Pseudomonas aeruginosa infection. The femoral thrombosis disappear. We look at it, and he was transferred to a rehabilitation unit. And I think it was one of the options that is feasible. So my conclusion for this case is for DTR organism, clearly discuss the need for a real treatment. And probably in some cases, if the patient is not too severe, probably a watchful waiting attitude could be discussed in some cases. So it was my last slide, and thank you for your attention.